Наступна доповідь у нас онлайн. Іван Stupac з Молдови. Доповідь «Ефективність черезшкірної трансфорамінальної ендоскопії в лікуванні гриж міжхребцевого диску».
Дякую. Дякую за возможность представить мой доклад. Спасибо большое Валентину Пьянковскому, который помог развить эндоскопию в Республике Молдова, помог мне. И спасибо Джириш Датару, который помог понять 3D-мышление в этой области. Мой доклад сегодня будет на английском языке. So, percutaneous endoscopic transforaminal discectomy is a contemporary approach in the surgical treatment of herniation, degenerative disc diseases of the spine. That gives us a lot of benefits. These new technologies, like reduces the local tissue damage, less blood loss, decreased wound pain, early return to the function than traditional approaches. In the article which was published in the Neurosurgeon Spine Journal, that was a comparison between open microdiscectomy tool system and endoscopy discectomy, the majority outcomes was reliable the same, like operative time, blood loss, complications, but a comparison, the clinical outcomes, endoscopy discectomy has a good improvement. I think it's not just for transforaminal, it's also for interlaminar and UB. Principles are very easy. It's like local anesthesia, minimal invasive incision, rimming SAP, endoscopic visualization that gives us a safe removal and early rehab of the patient. In 2022, in NAS conference, there was an article that was given the Value Abstract Award that demonstrated that percutaneous transforaminal endoscopy is equivalent efficiency compared to microdiscectomy, but has moderate clinical outcomes. So we know that we began with the disc herniation, open disc surgeries, microdiscectomy, assisted endoscopic interventions, and now we are in full endoscopy. The transforaminal philosophy, as you know, was in contemporary area was developed by Anthony Young with his inside-out techniques and outside-in by Thomas Huchand, which gives us the opportunity to have access to pain generators like disc, exiting nerve root, transversing nerve root, epidural space, superior facet, foraminal osteophytes, facet hypertrophy. So we have traditional surgery dilemma, which is developed by evolution of the new technologies, step by step, patient interested in quick recovery, and as we doctors are interested in less complications during surgery and post-operative time. That's why we have transforaminal endoscopic wind of change. So it's all about local anesthesia, minimal lesion of anatomical structures, skin SAP, avoid the formation of the scar, preservation of the lamina and ligamentum flavum, safe removal of disc pathology with ventral decompression, which is very important, gives us the opportunity to see the pulsating nerve root, disc access to extraforaminal, foraminal spinal canal pain generators. So the indications for the disc herniations are all of them nowadays due to the new technologies, and of course for the recurrent disc herniations. Contraindications, it's a general part that we say it's high risk, but today it's not a problem. We can go medially to the midline or we can go trans-iliac approach. Also, we have spondylolisthesis, metastasis, major stenosis, but it depends on the experience of the surgeon. Of course, for the point of view is the Campen triangle. For my fellows, I every time recommend them to begin with the transforaminal infiltration that gives them a clue to find out the disc and to fill the SAP. That gives us later in the operating room to use less time to find out the superioritical process. For the preoperative planning, it's all about understanding correctly the location of the disc herniation, type of independence of grade 1, 3 of the disc herniation, and understanding the arrangement. We have anatomical arrangement, it's all about the skin entrance, like anatomical and geometrical, and of course reliable to the MRI preoperative managing. Under local anesthesia, usually I use 1% lidocaine, almost 20 milliliters in order to, from the skin to the SAP, where on the SAP I use 2% lidocaine, almost 2 to 3 milliliters, even though I go to the disc if it is a painful disc. The same time using medial branch block in order to have a good relief for the patient. After this, we have the insertion of 18-gauge needle with dilatators. Of course, it's very important to know where it is the pain generators, and the docking, it's a very important part. During the drilling, knowing the element of vertical and horizontal part of SAP, I divided the vertical part in 3 parts, and independence of the migration of the disc herniation, I do the orientated targeted rimming, so I can grab automatically with different instruments the disc herniations. So the advantage is it's the local anesthesia that is interested about all my patients. They're afraid of these small incisions, have a good cosmetic and less blood infection or bleeding, minimal muscle damage, targeted approach, fast recovery on almost 3 hours. The patient or go out and is discharged on the next day, and short period of time of rehab. In the an article published in the Global Our Spine, the question was about the endoscopic discectomy is the next gold standard. So due to clinical outcomes like OD score, duration of the surgery, overall complications, length of the stay in the hospital, it has all the endoscopic procedures may take the place of the microdiscectomy being a gold standard. So we are on the good step. My study is all about prospective 110 patients with average age of 38.1 years. I had patients on all the levels, most of them L4, L5, L5S1, L3, with a location in about most of them paracentral region, after this intraforaminal, central, and extraforaminal. That's why I analyzed using the VAS classification for the pain. We just was analyzed for a period of 1 year, so it was reduced to 3 times, even though the leg post-operative, even though in the operating room, we have good relief of the patient. McNabb criteria was excellent in 85%, 12 in good, because I had 5 recurrences. It's a normal thing, but I'm happy that I didn't have no cases of conversion to open surgery. I analyzed all the patients, no dysesthesia and infection or discitis, with operative time almost 1 hour, with a hemorrhage 10 milliliters. So average verticalization in 3 hours, hospital stay 1.3 days, with usual activity 7 to 10 days. I'll show you some clinical cases. It's up-migrated disc herniation that and the same at the level of the disc. So what I managed, I arranged in such way, taken first of all from the disc herniation, and then step by step moved to upper part and taken the disc. That gives us the step by step was nearby the nerve, so managed to find out the disc pulsation. Okay. Another clinical case that I want to show you, it's all about the 2 disc herniations, which is ipsilateral, that managed to arrange it on the same entry. This gives us the opportunity of endoscopic spine surgery transforaminally that permitted me to take it out, the huge disc herniation from L5S1, and then using the same approach, the same steps, had the opportunity to take it out at the L4-L5 disc herniation. Another clinical interest is all about huge disc herniation grade 3. It's all about that today, of course, this disc herniation, it's easy to make interlaminar, but I arranged it transforaminally, so I was more parallel to the SAP, and rimming more SAP, I could manage to take it all the disc herniation from that area and finding the pulsating nerve root. So home messages. Percutaneous transforaminal disectomy is alternative method to the open surgery and microdiscectomy with much more benefits. It allows us safe and complete removal of disc herniation by endoscopic visualization, and superiority of this in outcomes gives us a clue and reliable to our days now that take my place of microdiscectomy being as a golden standard in the lumbar disc herniations. Thank you very much for your attention.
Ivan, thank you very much for the nice presentation.